In this lecture, we will learn about childhood diarrheas or gastroenteritis. Gastroenteritis is one of the most common conditions affecting the children, more so in the economically poor communities. WHO, the World Health Organization, gives top priority to the prevention and treatment of gastroenteritis. Yet, globally, nearly 2 million deaths occur per year due to gastroenteritis. And all these deaths are easily preventable by administration of proper treatment. The family physician has a very important role to play in the treatment of gastroenteritis, not only by administering medicines and fluids, but by educating all the ladies and mothers who come with their children about proper, clean, sterile feeding and oral rehydration. Gastroenteritis mainly affects children below 5 years, and the maximum affection is in infants between 6 months to 2 years. In infants, gastroenteritis starts with fever and watery loose motions. It may be associated with vomiting, and the child becomes rapidly dehydrated. Initially, the child becomes thirsty, drinks eagerly, the tongue and mouth are dry, it is restless and irritable, crying. The eyes are slightly sunken, and the skin, when pinched, goes back slowly. Later, in severe dehydration, the child becomes lethargic, drowsy, or sometimes unconscious. The eyes are deeply sunken, tongue and mouth are totally dry, and skin turgor is lost. When pinched, skin remains pinched for a long time. The treatment of gastroenteritis is described in 3 plans according to the degree of dehydration. If there are no signs of dehydration, then treatment plan A is started. The child is managed at home with ORS and home available fluids. Instruct the mother to feed ORS continuously as much as the baby takes, except when there is vomiting or abdominal distension. Give 100 ml of ORS after every watery stool. You all know how to prepare ORS. There are several commercial preparations of ORS available in sachet form like Electral, Raylight, etc. Boil and keep 1 to 2 liters of water. Take 200 ml of boiled and cooled water in a clean glass and add 1 sachet of ORS to it. For poor patients, it can be prepared by taking 200 ml of boiled and cooled water and adding a teaspoonful of sugar and a pinch of salt. The child is very thirsty and will drink it eagerly. The mother should keep on feeding the ORS as much as the baby demands. Mothers often worry about 2 things: that the child is drinking too much water and that the water is just flowing down the stools. You must explain that it is the other way round, that what is lost in the stools is being replaced and that the child needs it. Gastroenteritis is undoubtedly a test of patience for the mother. The child is irritable, sleeps less, asks for only the mother, and the mother has to sit by the child day and night. The ordeal continues for 3 to 7 days, even with all our treatment. But the mother has to do it. There is no alternative. Now about breastfeeding. Breastfeeding should always be continued during acute diarrhea. If baby is on top milk, that too should continue. Milk feeding may slightly increase the frequency of stools, but it does not increase dehydration. Feeding milk helps mucosal recovery and maintains nutritional status. Even in acute diarrhea, there is 70% nutrient absorption overall, so milk feeding must be continued. A little older children, say about 1.5 to 2 years, may not be satisfied with ORS alone. They should, in addition, be given other home available fluids like rice water, dal water, buttermilk, coconut water, lemon water and plain water as per their liking. But avoid soft drinks, aerated drinks and sweetened fruit drinks. This was Plan A treatment for a child with no dehydration or minimal dehydration. Now we will come to a child with mild to moderate dehydration who will need the Plan B treatment. The child must be under doctor's observation for first 4 hours. 80 ml per kg body weight ORS should be given during these 4 hours. Make the mother and the child sit in the clinic and feed it. If after 4 hours the child is fine and the signs of dehydration have disappeared, then you may send the child home with proper instructions. ORS should be continued in the dose of 50 ml per kg for next 24 hours plus 50 to 100 ml for each watery stool. An average of 1 teaspoonful or 5 ml should be given every minute. But if after 4 hours the child still shows dehydration, then the child should be admitted and we may have to opt for treatment plan C. Let me stress again that in infants, breastfeeding must be continued irrespective of the degree of dehydration. And in addition to ORS, plain water and breast milk must be given. However, if the child is vomiting excessively or if there is abdominal distension, then oral feeding becomes difficult. And without hesitation, start IV fluids, start Ringer's lactate. Also, if dehydration is not corrected or increases in spite of oral fluids due to continuous loose motions, then also IV fluids must be started. Lastly, if the child has severe dehydration, is lethargic with deeply sunken eyes and loss of skin turgor and scanty urine, then we should shift to Plan C. This child should be referred to a pediatrician. Start IV fluids immediately and give Ringer's lactate. IV should be given fast and 30 ml per kg body weight Ringer lactate should be given in the first hour. Then give 15 ml per kg every hour for 4 to 5 hours so that in the first 6 hours 100 ml of fluid per kg should enter the body. Assess the baby after every 50 ml fluids and continue Ringer's lactate till eyeballs become normal, skin becomes turgid and sunken fontanelle becomes flat. Usually 150 to 400 ml of Ringer's lactate is required. Once the skin becomes turgid, stop Ringer's lactate and start Isolite P and continue Isolite P 100 ml per kg in the next 24 hours. As soon as the child is alert, feeding of ORS and breastfeeding should continue. But let me warn you once again, if the child is listless or unconscious, dehydration is severe, if pulse is feeble or respiration is deep and sighing, then do not waste time. Take the child to a pediatrician immediately. Till now, we learnt about fluid replacement in gastroenteritis. Now we shall see what other drugs are to be advised and given. I have tried to stress the importance of fluid replacement because it is the most important thing in gastroenteritis. The child will get well with only fluids, no drugs, but not with drugs without fluids. At the same time, it is important to control the intestinal infection and hasten the mucosal recovery by giving appropriate drugs. To control infection, we give an intestinal antibiotic. Actually, most of the cases of gastroenteritis are due to viral infection, so antibiotics are not needed. Antibiotics may be given only to those cases with fever, blood in the stools or severe diarrhea. But in practice, a mild antibiotic syrup is always prescribed, usually ofloxacin, Septran, Gramoneg, that is nalidixic acid, or colistin. And if bacterial infection is suspected due to fever, severe diarrhea, or blood and mucus or foul stools, or if the child is malnourished, then injectable higher antibiotics like gentamicin, amikacin, and cephalosporins should be given. Then the symptomatic treatment. If the child has vomiting, give syrup ondansetron or syrup perinom. If the child has intestinal colics and is crying, give syrup spasmindon. If frequency of the stools is more, give tab loperamide half tablet TDS. The skin around the anus may get inflamed or excoriated if it remains wet with the watery stools. So after every motions, clean and dry the buttocks, apply talcum powder, and if redness of the skin is seen, apply zinc paste or xylodum ointment. It is very important to keep the skin around the anus dry. Apart from this, we consider 3 more drugs. A new drug is now commonly used, that is resicadotril. Ridotil 15 mg sachet dissolved in water is given 3 times a day if the motions are watery. It improves intestinal absorption of water and reduces fluid loss. A very nice concept, but is still considered to be of doubtful value. The second drug is Lactobacillus. Whenever higher antibiotics are given, or if diarrhea is prolonged for more than 3 days, then the normal intestinal flora gets disturbed or destroyed. So we must prescribe Lactobacillus, for example, Lactiflora sachet in water once daily. It helps to restore normal healthy intestinal flora and must be given after higher antibiotic treatment. Another new and commonly accepted concept is to supplement zinc 20 mg per day for 2 weeks to reduce watery diarrheas. Prescribe Zioral or ZND syrup or 20 mg dispersible tablet once a day for 15 days, and in recurrent cases continue it for 4 to 6 months. At the end, understand that gastroenteritis is easily preventable. Simple hygienic precautions will prevent most cases of gastroenteritis. Instruct the mother to clean the nipples before breastfeeding. More care should be taken if the child is bottle fed. Boil the bottle and the milk before every feeding. Improper cleaning and boiling of the bottle is the reason behind many diarrheas. Also, weaning should not be delayed. At the end of 1 year, the child should be eating everything that the family eats, only that it should be in a soft form and without chilies. Many times, 1.5 to 2 years old children are still taking only milk, with the result that they are malnourished and prone to develop gastroenteritis and other infections. So proper feeding at appropriate age is extremely important. These simple practical instructions should be given by you to the families under your care, even if they have not asked for your advice. Most children under 5 years will get 1 to 3 mild episodes of diarrheas in a year. But if treated in time and with proper drugs and fluids, there will be no cause for worry and no dehydration. To end this lecture, let me revise what to look for and examine in a case of child with watery motions. Ask about the frequency and quantity of the motions. Is the child thirsty? Does it drink water very eagerly? Look at the skin turgor by pinching the skin over the abdomen to raise a fold and see how rapidly it flattens out when released. If anterior fontanelle is present, is it turgid or sunken? Are the eyeballs sunken? When has the child last passed urine and how much? Is the urine output scanty? Then, is the pulse of good volume or rapid and thready? How is the respiration? Rapid, shallow or deep? And is the child alert, drowsy, or unconscious. Considering all these findings, decide the degree of dehydration and then institute the treatment plan A, B, or C